This is QD Clinic. Hi, I'm Jack Cush with RheumNow.com. QD Clinic is brought to you by RheumNow.live. Great meetings like this are attended by great rheumatologists like you. It's going to be January 27th and 28th in Dallas. It's a few months away. Be sure to register. Today's case is pleuritis in rheumatoid arthritis. Kind of an easy case, don't you think? 37-year-old woman presents with a 2-day history of chest pain, difficulty breathing. It's on the right side. She's had rheumatoid arthritis for 4 to 5 years. She was doing well. She was taking standard medicines, methotrexate, prednisone, TNF inhibitor, a little bit of Salogen, pilocarpine. And then she developed 2 days ago this dyspnea, some orthopnea. She said she felt like she was going to faint. When she took a deep breath, it got progressively worse. It was worse with inspiration and with lying down. She went to a drive-in clinic, not the emergency room. They did a chest x-ray, said she had pleural effusions. A day later, she went to the emergency room where she was diagnosed with pleuritis and some pericarditis based on the chest x-ray and also on an echo. The echo showed a moderate pericardial effusion with a normal ejection fraction and no evidence of tamponade. Her history was that for rheumatoid arthritis with some evidence of sicca symptoms for which she was supposed to take pilocarpine 3-4 times a day and was just taking a PRN. She has no other medical illnesses other than childbirth. She has no consequences to her almost Sjogren's syndrome. She denies diabetes, hypertension, heart disease, other infections, recent infections, or other new drug use. Her medicines, she's treated with methotrexate, hydroxychloroquine, I believe etanercept in the past. Now she's taking methotrexate 17.5 milligrams a week, golimumab 50 milligrams a month, prednisone 5 milligrams a day, and as I said, PRN pilocarpine. When you ask her further history, she has no recent infection, not taking antibiotics, denies fever, actual syncope, visual changes, edema, etc. When you do her labs, she's got a CRP that's normal, but the SED rate is 57. She's strongly positive for rheumatoid factor and CCP. She has a little bit of a lymphopenia at 900. Her ANA is positive 1 to 160 in a homogeneous pattern, and her double-stranded DNA is negative. She undergoes thoracentesis in the emergency room. They relieve 1.5 liters of straw-colored transudative fluid from her chest. She feels much better. They put her on prednisone. The question is, why does she have pleuritis? What's the differential diagnosis? I must say, I immediately rushed to TNF inhibitor-induced drug-induced lupus, which turned out to be the right diagnosis. But I think you have to go through the process of what else could this be? And I think you have to recognize RA comes with a fairly good risk of lung disease. And RA pleural effusions, I must say, I saw a few of in my early days of rheumatology. I haven't seen a RA pleural effusion in probably 25 years. But if it happens, you know, the test question answer is that you get low glucose in either pleural or pericardial fluid when it's due to RA, and that could be a diagnostic clue. You can make other diagnostic clues by finding, you know, rheumatoid factor in there, or by doing pleural biopsies, looking for distinctive findings of rheumatoid arthritis, mainly nodule kind of findings. But honestly, no one really needs to have a pleural biopsy to make this diagnosis. However, if it's other diagnoses with RA, recurrent pneumothorax, I've had a few of those, and they're always due to nodules that invade the bronchi and lead to pneumothoraces. Alveolar hemorrhage, related to underlying pneumonias. see RA patients, either the therapies you're using, getting opportunistic infections. TB is tops on the list, and that also gives you a low glucose. But other fungal infections will do this, and those are more likely with TNF inhibitors than other biologics. The other biologics, the non-TNF biologics and JAK inhibitors, don't really cause opportunistic infections that would lead to, you can get infections, serious infection, but opportunistic infections, again, everything from Candida to MAI to leishmaniasis, again, that's going to be a TNF inhibitor driven risk, much more so than with abatacept, IL-6 inhibitors, IL-1 inhibitors, JAK inhibitors, and even rituximab. You have to worry about malignancy because, especially if the patient's over age 40 or age 50, this patient's young and 37, you have to worry about the co-occurrence of lupus. Maybe, there are those patients who get rhupus, RHUPUS, and this might be one such scenario. And then lastly, drug-induced lupus, with TNF inhibitors being probably the most common cause of drug-induced lupus these days. The list is available on RheumNow.live. Look for the rheumatology card at the top of the page. They got a list of drugs that cause this. The historic risks were with hydralazine, procanamide, quinidine, alpha-methodopa. But also now the most common ones, I think, are really going to be, let's go with the uncommon ones still. Isoniazid, penicillamine, dilantin, tegretol, thorazine, lithium, sulfasalazine beta blockers. I think the more common ones these days are tetracyclines and TNF inhibitors. Also, but I guess maybe the TB drugs. But ACE inhibitors, TNF inhibitors, ticlopidine. There is this other kind of drug-induced lupus where they manifest with subacute cutaneous lupus-like lesions, either papulosquamous or the psoriasiform lesions. And that's not uncommon when you're using a PPI, like omeprazole, hydrochlorothiazide, and also calcium channel blockers. In this woman, she was on a TNF inhibitor. She was doing well. We had to switch her to another drug. She's done fine on the alternative, other non-TNF biologic, and this problem resolved. She took steroids for probably 4 weeks and went back to her in a higher dose. I think she was given initially some IV in the hospital and then was given like 40, 30, 20, 10, and then back to her daily 5. The real problem is getting off for 5 milligrams of prednisone, is it not? Anyway, that's it for this case and QD Clinic. Again, go to RheumNow.live and check out our program and agenda. I think you'll like it.